we can have good mental health, we can have mental distress, we can have a mental disorder, and we can have a disability. And a pandemic like this actually shifts the whole spectrum towards the right. That means if we had good mental health, we have slightly less good mental health at this time. If we had mental distress, then the distress increases, and there is a possibility that some of us will actually go into a mental disorder. And if we already had a mental disorder, our disability because of that can increase. And so this is the dimension that happens. And during conflicts and disasters, also amongst refugees, but also during pandemics like this, the whole curve shifts towards the right. And there is more symptoms, more disorders, and more disability because of that. And these are all related to the excessive stress that we are all facing. It also means that everybody may need help to a small extent or to a large extent. And in some cases, the stigma of having a mental health problem may actually be decreased, because now if everybody needs help, there is less stigma. Earlier, people who had a mental disorder were very shy of, very reluctant to open up and say they have a problem. But during these times, when everybody has at least a small problem, the reluctance to convey that one is going through a problem might actually be reduced. So that may be one of the small benefits of a crisis like this, because it might decrease the stigma and increase the openness with which we can share our psychosocial experiences. We conducted a meta-analysis of prevalence for mental disorders in conflict settings a couple of years back, and it turned out that 1 in 5 persons had a mental disorder if they were affected by a serious conflict. We know that pandemic is not the same as conflict, but we believe that these findings are very similar to what can happen during natural disasters like earthquakes, like tsunami, like any other natural disaster, or during a pandemic like this. So there is enough reason to believe that during these times, at least 1 in 5 persons will have a clear diagnosable mental disorder, and many others will have mental health problems. During pandemic like this, there are several impacts on health, and this chart shows you some of them in an illustrative way. So if you look at the first wave, that is the immediate mortality and morbidity because of COVID-19, which is very sudden to come in and very high proportion. So a number of populations, including China some time back, but now many other European countries, some American countries, and some other Asian countries are facing the brunt of excessive number of people getting infected and a high death rate. But this is not the only problem that is we are going to face in the health area. There will be another phase where there will be psychological issues, the phase 2, psychological trauma, mental illness, burnout, and worsening of the situations of mental health for majority of people, which is already seen to be rising, and this will continue to rise, which is followed by the phase 3 and phase 4. In phase 3, there will be the impact of resource restriction on urgent other health conditions, which are non-COVID. And phase 4 is the impact of interrupted care of other chronic conditions, like diabetes, like heart illness, like respiratory illness. But what I want to show here specifically is that the psychological and mental health impact are actually very large, and they continue beyond some of the other phases. So you can see on the red and orange line that the impact of these is not only immediate, but it lasts a long time. And so when we are thinking and trying to flatten the curve of COVID infections, we should also be looking at flattening the curve of the mental health problems, which are going to pose a very serious problem for the societies which are facing the impact of COVID-19. In spite of the short duration in which we have seen the COVID pandemic, there are many studies that have been done. I am presenting just two of them. The first one, which is on this slide, was conducted in China in February 2020, which was a very large survey of more than 52,000 respondents from all over the Chinese-speaking people. And it turned out that 35% of the respondents experienced psychological distress, which is 1/3 of the total population. And a higher amount of distress was felt amongst women, amongst people between 18 to 30 years of age, but also more than 60 years of age. So amongst young adults who are finding very difficult to get education and to work during this period, and also amongst older people whose movements were restricted much more and who had a much higher risk of getting the infection and also suffering a large amount of health problems, including the death rate, which was very high amongst the older people. The higher distress was also there in high infection regions, the red zones where the infection rate was very high, and also amongst migrants who were in many cases stranded in areas that were not their home. So we can see that even by this very quick and in some non-systematic surveys, the number of people who experienced the mental health problems was quite high. And the second slide here shows you that the coronavirus had a very negative impact on mental health in a country like USA, where again a survey showed that people who had worry or stress related to the coronavirus was having a major impact in almost 20% of people and a minor impact on another about 30% of people. So overall, about half the people who were surveyed had some problem, either minor or major. And it is very likely that these two surveys, one in China and one in USA, are in some way illustrative of the mental health problems that are being faced and will be faced in many other countries and many other communities which are facing this problem. So in this part of the presentation, I want to convey a very clear message that 1/3 to half the people who are impacted by the COVID-19 will have some mental health and psychological problem, and about 1/5, about 20% of people will have a diagnosable disorder which all require help. So now let's see what are the kind of mental health problems which are faced. We know that a large number of people are facing it, but what are the kinds of problems? We begin with the most common, which is anxiety disorders and depressive disorders, but it's also followed by some others, which is like post-traumatic stress disorder, substance use disorder, including alcohol and drug abuse, in people who had these problems earlier, but in some cases, people start taking more of these substances and get into more serious problems, even if they had a problem earlier. Another issue is gaming disorder, which is excessive use of online or offline gaming. And you might recall that WHO included gaming disorder as a psychiatric disorder last year in the ICD classification. And this is especially common in Asian countries where gaming, especially by young people, is becoming a major public health issue. And during times like COVID, when a lot of people are confined to their homes, they cannot attend school or college, they cannot go to work, the use of gaming devices is increasing in terms of time. And not all, but at least a small percentage of people who are having gaming as a major occupation of their time will undergo a decompensation on their gaming. and some of them might actually be going into gaming disorder, which can have a serious disability. There is also the possibility that there is a relapse of other disorders like bipolar disorder and psychoses in people who had these disorders earlier, and they undergo relapse and they undergo some decompensation because of many reasons, one of them being that their care is interrupted. There is also increased disabilities associated with people who have intellectual disabilities, people who have dementia, and people who have other neurological disorders, again because of the same reasons that they are now not able to utilize the all the functionalities and also interact with the environment in the same way that they were able to do earlier. So the disability increases and their usual social support systems are compromised during this period. That also is one of the reasons that these disabilities are increased. There are many factors which influence the onset of mental health problems, psychosocial issues, and also increase in the disabilities because of mental health problems. I will list some of them here. One of them is obviously the direct effect of COVID-19, because in some countries, the percentage of people who are getting infected is substantial. And in many cases, this infection rate is going to increase. In fact, for every person who gets infection and who has an illness, there are many other people who get affected. And so there is a direct as well as indirect effect of the COVID-19 on people and on communities. Because of the rapid rise in the infection rate and death rate, there is a large amount of fear and concern about the disease in the communities. And that's again a very major reason why people are very worried, people are apprehensive, and they undergo anxiety. There is the fear of illness and death amongst family members, colleagues, and friends. But added to these more direct impact of COVID-19, there is also the impact of regulations and restrictions. For example, restriction in movement. Millions, in fact, now billions of people all over the world are confined to their homes. They're asked not to step out of their homes, not to go to work. And all of these things create a very large amount of stress, together with a loss or uncertainty about their job. In fact, many people are not able to attend to their jobs. Some of them are they're losing their jobs, and there is a lot of uncertainty as to when they can get back to job in a factory, in an office, in agricultural work. And so all of these factors give rise to more stress and more mental health problems, together with loss or reduction in income. A number of people who rely upon daily income are not having that income. And so there is increased amount of poverty. There is also change in day routine and schedule. Your regular daily routine of work, of pleasure is being completely interrupted. Some of the people are away from their home and family, and there is increased impact of loneliness. Some of them are staying alone with no social support. There is the problem of child care and elder care, because the schools are closed, child care facilities are closed, and some people might have in their family a number of adult people as well as elderly people who require personal care and also social care. And all of these things give rise to a lot of stress on people. And finally, lack of health care for other ailments, because most of the health system has become too busy with looking after the COVID. So all the doctors and nurses are busy to look after that. And the routine care for pre-existing illnesses, like chronic illnesses, like cancers, is all suffering because there is nobody to look after that. And also the supply of medicines and other diagnostic interventions is being completely interrupted. In fact, many hospitals do not at all care for other disorders than COVID. So all of these give rise to a larger impact of mental health in the populations that are being affected. The whole population is getting affected, but there is a group of vulnerable people. Obviously, the elderly are very vulnerable. There are also people with pre-existing disabilities, whether physical or mental, and people with pre-existing mental disorders, especially people with severe mental disorders, including psychoses, dementia, and bipolar, are especially vulnerable because some of them cannot look after themselves and they rely upon others, and those others might actually be either not available at all or might have other preoccupations. So these are vulnerable people. There is also the people who are staying in institutions, either prisons, jails, mental hospitals, and other social institutions, especially nursing homes, where the usual care is not available and the infection rate actually might be quite high. Also, people with physical diseases, women are at more risk as such, but also because of domestic gender-based violence, which in some countries have shown a very large incidence of gender-based violence because they're confined maybe with a partner who has already indulged in violence, and this provides an opportunity to do that more. So, and they may not have any recourse to help. Also, people who are dependent on alcohol and drugs, and actually the supply of alcohol and drugs might decrease, and so they might be more vulnerable to have withdrawal symptoms, which can be sometimes very severe. People with extreme deprivation, for example, very poor people or marginalized people, they are more vulnerable. And finally, people who are homeless or living in crowded, impoverished localities. In many countries, there is a large number of people who stay in these settings are much more. These are just some examples, but in many countries, there are many other examples of people who might be much more vulnerable. And as mental health professionals, it's our responsibility to look after these vulnerable people in much larger way than for other people. In the last few years, a lot of literature has been accumulated about the impact of social isolation and loneliness on our health, and in fact, even on our mortality. This slide presents in a figurative way some of these impacts. Social connections are extremely important for human beings. We are social animals and we depend on social interactions to look after ourselves as well as the community. And so social isolation, loneliness are responsible for a lack of social support, which acts as a risk factor and it mediates the health impact. In fact, many physical as well as mental disorders can be there because of social isolation. It can be long term, where the effect is much more, or it can be short term of many weeks and months, but still there is an impact, which give rise to diseases, but also a higher mortality. In fact, some of the studies have suggested that social isolation and loneliness are actually responsible for a very large amount of mortality. People do actually die because they are socially isolated. And this has to be considered as we plan the response to COVID. I would like to emphasize the fact that majority of countries and even international organizations are talking about social distancing, which actually is quite an unfortunate choice of phrase, because actually what they mean is physical distancing. In fact, what should be there is physical distancing with social connectedness. Social distancing as a strategy for preventing transmission of virus is actually not a very good construct. We should be talking about physical distancing, which is necessary for safety, but a higher amount of social connectedness and support, which is very important. So it perhaps requires a change in the communication strategy to emphasize physical distancing with social connectedness, which is quite important to do. Similarly, taking care of mental health during COVID-19 pandemic is an issue that should take a lot of time and effort and emphasis by policymakers as well as by healthcare providers. Giving correct, timely, and credible information is extremely necessary because uncertainty and lack of information give rise to more anxiety and more depression. We should also emphasize that there is a lot of wrong information or misleading information which has been termed by WHO as an infodemic, just like a pandemic, and that can have a very adverse mental health impact. Our recommendation also is not for people not to overload themselves with too much news or too much negative news. Follow a daily routine as much as is possible. And as I was saying earlier, stay connected with others in whatever means are possible, including use of phones and other internet-based devices. It's also important to recognize and accept your own level of stress because it is expected. Anybody who's facing this kind of issue will have a level of stress, and it's good to accept that because we are all vulnerable to that. We should take time to do something positive, something that we like, something that we derive pleasure in, which is extremely important. But also, it's important to show empathy to others, show gratitude for what others are doing to us, and also help others because helping others is also a means of helping ourselves. We should also look after our sleep, nutrition, and physical activity. We understand that in some cases that is not possible because the nutritious food may not be available or the possibility to have physical activity may be limited, but we should try our best to do that. And finally, not indulging in the use of tobacco, alcohol, or drugs is a very important strategy. When I was working for WHO, we provided this pyramid of mental health services. I'm now coming to what can be done by mental health services. At the bottom of the pyramid, there is the self-care and informal community care, which should be available to everybody, especially during these kind of pandemics. Everybody deserves for having self-care, guided self-care, as well as informal community care. And some people might need primary care, and mental health services should be delivered by general doctors and nurses. A smaller number of people will require psychiatric services in general hospitals as well as in community-based mental health services. And a very small number of people will require very specialized help. This is a good public health approach because the bottom of the pyramid, which is in green, costs very little. It requires very little resources to give that, and it should be available in large volume. And the top of the pyramid costs a lot and should be available only for those people who really need that. And so this is the way mental health services need to be organized during normal times, but also during the time of pandemics. So this is something that needs to be done by health authorities to do that. In WHO, we believe that mental health care can be provided by non-specialized healthcare providers, and the MHGAP intervention guide is a technical tool along with the guide, but also a lot of training material which are available, and I believe also in Chinese language, which can provide a lot of help for training people how to look after the mental health issues. And also there is a MHGAP app which can be downloaded on a phone or any other device and can actually provide the kind of resources that are needed for mental health care. Another document which is also available in Chinese language is Psychological First Aid, which is the WHO document. And this provides guidelines about how a very light touch psychological first aid can be delivered by trained lay people in times of conflicts, disasters, as well as pandemics for taking care of some of the smaller mental health issues. But if there is more in-depth psychological treatment necessary, which some people will require, there are also other manuals which are available. One of them is Problem Management Plus, which has been proved to be of evidence, and this many good studies are available, and this document is also available. And the good thing about this document is that it's transdiagnostic. That means it is useful for stress, for depression, as well as for anxiety. So it can be delivered by trained providers who are not specialists, not having a PhD or other high degrees, but trained providers with a short amount of training can actually deliver this kind of intervention. And another intervention is group interpersonal therapy, which again can be delivered by trained people in relatively less rich environments in a good way. One of the issues is also how to look after children and their mental health problems during the time like this. And there is also a parents skills training manual, which is available from WHO, which provides good advice on what the parents can do for their children and how good parenting can be useful during normal times as well as during these times. International organizations like WHO as well as the Interagency Standing Committee on Mental Health and Psychosocial Issues have come out with some very quick but very useful guidance, and these are worth looking at. These were both developed in the last few months for organizing the mental health and psychosocial care during times like this. I will end my presentation by requesting the organizers to present a video which was made by WHO a few years back, which is for general purpose. So it describes the phenomenon of depression, and it's a public education video which illustrates how depression is a mental health problem, how to recognize that one has depression, and what to do if one has depression. So it is a 4.5 minutes video, which I hope will be useful for you to understand that depression is a very common condition. A lot can be done to recognize it and also to look after depression. This obviously is meant for general public, but I'm sure that a lot of health professionals will like to watch it, but also use that amongst their practice and amongst public education campaigns to look after and to provide the kind of information that is available for general public. And I hope you will watch it and also will then use it. It's freely available on YouTube. And so I end my presentation here and ask Norman or Neo to run this video. Thank you.
好，谢谢。那我们接下来一起跟随 Saxena 教授来带给我们的这一段4分钟的关于抑郁症的视频，有请。
I had a black dog. His name was Depression. Whenever the black dog made an appearance, I felt empty and life just seemed to slow down. He could surprise me with a visit for no reason or occasion. The black dog made me look and feel older than my years. When the rest of the world seemed to be enjoying life, I could only see it through the black dog. Activities that usually brought me pleasure suddenly ceased to. He liked to ruin my appetite. He chewed up my memory and my ability to concentrate. Doing anything or going anywhere with the black dog required superhuman strength. At social occasions, he'd sniff out what confidence I had and chase it away. My biggest fear was being found out. I worried that people would judge me. Because of the shame and stigma of the black dog, I was constantly worried that I'd be found out. So I invested vast amounts of energy into covering him up. Keeping up an emotional lie is exhausting. Black dog could make me think and say negative things. He could make me irritable and difficult to be around. He would take my love and bury my intimacy. He loved nothing more than to wake me up with highly repetitive and negative thinking. He also liked to remind me how exhausted I was going to be the next day. Having a black dog in your life isn't so much about feeling a bit down, sad or blue. At its worst, it's about being devoid of feeling altogether. As I got older, the black dog got bigger and he started hanging around all the time. I'd chase him off with whatever I thought might send him running. But more often than not, he'd come out on top. Going down became easier than getting up again. So I became rather good at self-medication, which never really helped. Eventually, I felt totally isolated from everything and everyone. The black dog had finally succeeded in hijacking my life. When you lose all joy in life, you can begin to question what the point of it is. Thankfully, this was the time that I sought professional help. This was my first step towards recovery and a major turning point in my life. I learned that it doesn't matter who you are, the black dog affects millions and millions of people. It is an equal opportunity mongrel. I also learned that there was no silver bullet or magic pill. Medication can help some, and others might need a different approach altogether. I also learned that being emotionally genuine and authentic to those who are close to you can be an absolute game changer. Most importantly, I learned not to be afraid of the black dog, and I taught him a few new tricks of my own. The more tired and stressed you are, the louder he barks. So it's important to learn how to quiet your mind. It's been clinically proven that regular exercise can be as effective for treating mild to moderate depression as antidepressants. So go for a walk or a run and leave the mutt behind. Keep a mood journal. Getting your thoughts on paper can be cathartic and often insightful. Also keep track of the things that you have to be grateful for. The most important thing to remember is that no matter how bad it gets, if you take the right steps, talk to the right people, black dog days can and will pass. I wouldn't say that I'm grateful for the black dog, but he's been an incredible teacher. He forced me to reevaluate and simplify my life. I learnt that rather than running away from my problems, it's better to embrace them. The black dog may always be part of my life, but he'll never be the beast that he was. We have an understanding. I've learned through knowledge, patience, discipline and humour, the worst black dog can be made to heal. If you're in difficulty, never be afraid to ask for help. There is absolutely no shame in doing so. The only shame is missing out on life.
Thank you.
这个抑郁的一个非常感谢您的介绍。
Thank you for your introduction. Next, we have seen the video, the depression video, and often the depression happens in our life, and it was depicted like a black dog. This is from Churchill. He said that depression is like a black dog, and sometimes it just bites us. So it has become a symbol for depression. And today, in our course, we will need to focus on another topic, because mental health has been an area that needs more investment and needs more public recognition. And during the COVID-19 outbreak, we have this team. They're from psychological department. They went for the Wuhan city to support everyone there and to provide mental service. And next, we'll have with us Professor Wang Xiaoping. He has been in Wuhan since February 21st, and we have seen the Fangcang Provisional Hospital, and this is also part of the work of Professor Wang Xiaoping. And we will follow his step and to learn from his experience in Wuhan. Please.
好的，谢谢介绍，也
Thank
很
you
有
for your
很有
introduction.
幸的参与这一
I'm
次
very honored to
活
be
动。
part
那
of
么
this
花点
course,
时间来跟大家
and
分
I'll
享一
spend
下
some
有
time
关
to share with
这一
you
次
some of my
有关在武汉的一
experience
些工作。
from
那么
Wuhan.
前面也提到过，这次武
And
汉
it has been mentioned
新冠肺炎
before
这个疫情
that
呢，就是
COVID-19
调动了我们国家所有的医疗资源，
and
一个
has
很大一块的医疗资
mobilized a
源。
lot of medical
其他
resources
其中就
in
包
our
括
country,
前面我们讲的，
which
包括我们
includes
精神心
our
理科的一些服务。
psychiatry
那么
department
这次
and
我们觉得这
psychology
个服务也
department.
是
We have
非常及
provided
时的。
several mental
前面提到
health,
过，我们
several
在
different kind of
2月
mental health to
20号
Wuhan.
国家卫健
We
委就
were
组织了这个团
we
会。实
arrived
际上
in
我了
Wuhan
解，我们去了以后了
in
解，
February
其实在我们很多
21st.
我们
And
救
as
治
far
团
as
队
I
早期他们
concerned,
也是
there are a lot
也
of rescue
是
teams
派了
there,
相关的一些心理服务
and
的队伍参与了这个
with
活
the
动。我们单独组建了一
themselves
支国家心
several
理医疗队。那么这个医疗
mental
队的话，一共
counselors.
的话是
And
一共
on the 21st of
有
February,
302
the
位，
National Health
来自
Commission
于有
Medical Management
8
Bureau
个省。
has
我
put
们湖南
together
省的话
a psychological
大概
team
是
for patients and frontline health workers in Wuhan. We
湖南
have
省的话一共是50位，其中
from Hunan province 50 people.
其中我们
And among these
科的
50
话一共
people,
去了15位。
there are
那么
15
15
from
位的
our
话，我们
department.
一共我们就负责了有
Among these
4家的这
15
个方舱医院和5
people,
家这个
we
定点医院，有
scattered
9
in
个
the
医院。
provisional
那么实际上我
hospital
们还
and
有一队我们
designated
是负责
treatment
其他的。
hospitals.
那么实际上是每个医
So
疗机构，那就相
basically,
当于是5
every
位。
health
5位里面
facilities,
我们
we
大概包
have
含了我们真
approximately
正科医
5
生，也包含了我们的心
psychological
理治疗
healthcare
师，
workers,
还包
which
含了我们的心理
includes
咨
the
询师。那我
psychiatrists,
们
the
主要的目
psychotherapists,
标，当
and
然我们主要
psychologists.
是第一个
So
是
our
为我
main
们
aim,
新冠肺炎的患
main
者，
objective
那么
is
还
to
有就是我们一
provide
线的
for the
医
patients
务人
and the
员提供这个
frontline
心理支持
healthcare
的。我们主要
workers
目的是这
to
个
provide
目的。
them with psychological
那么
support.
我
This
简
is
单，因为时间
our
关系，我简单
objective.
介绍一下，比方说我们
I would
参
like
与其中
to
方舱医院里面，
introduce
我们有一
provisional
家就是武
hospital,
昌的
the
方舱
Fangcang
医院，大家应该
Hospital,
听说过，
briefly.
这是第一家方舱医院，也是最后
First
一家
provisional hospital.
关闭的医
And
方舱医
also,
院。
this is the last
那么这个
provisional
方舱医院是
hospital to be
当时把
closed
武
in
汉的一
Wuhan.
个
At that
红
time,
山，这个武昌那个红山一个体育馆，把它改
there
造了，
was
花
a
2天时间把它
Hunan
改好。当时这个
gym,
方舱医院里面有
gymnastic.
3个
There
区，有
was
8个的床
the
位。
gym was
那么当时因为我们知
designated
道
for
方舱医院的
provisional
话，主要是
hospital
收治那些比
with
较
800
症
beds.
状，就是这种肺炎性不好
Basically,
的轻
we
微的轻
admit
的一些患者。
mild
那么
patients
这些患
with
者里面大家知
COVID-19.
道，因为
And among these
他本身
patients,
这个病情躯体
they
这个
have
肺炎病情不严重，
they
那
have
么
very
集
mild
中在一块，主
COVID-19
要是有
disease,
利于我
very
们讲
mild
切断这个
pneumonia.
传染源，跟这个是很大的
We
关
need
联性
to
的。
cut the
那我们去了以
source
后，
of
我们讲他
infection,
这
so
个
we
这
have
里面
them
的
in
问
the
题，大
provisional
多数我们发
hospital.
现也就是一些
And
像
among these
睡
patients,
眠的问题，
we
睡
discovered
眠障碍
that they have some
这个
sleep
多一点，
disturbance.
还有就是焦
This
虑
is the
情绪，我
major
们焦虑症状或
problem.
者是
And
焦虑
also,
情
some of
绪，
them has
这个情况也比较多
anxiety.
点。而且这
This
个
is
焦
also
虑
very
很多是
common. Most of
伴
the
随着是跟
common,
我们有些是
most of the
躯体症状表现
anxiety,
比较多的。
they
那
have
么还有
somatic
少量的，其实我们
symptoms.
看了一下，少量的
And
有精神
also,
发作的，
we
不
have
是很
several
多。
panic
那么
attacks.
抑郁的，其实
There
在
was
早期
a
我们看的，
handful.
在患者群里面也不
And
是
for
很多。
depression,
那么还有少
in
数的
early
就我们
phase, we
说一些
didn't
精神
see
病情障碍
much.
的。
And
这一
also,
块的
we
话有
saw
2
some
种情况，
psychotic
一种情况
disorders,
的话，
which can
就
be
是有
divided
些
to
本
two
身就有
categories.
既往，就是
First,
有病史的。
they have
那
a
么
past
住
medical
院以后，
history
有
for
些
psychotic
是在继续
disorders.
在维持治疗，有
After
些是
admitted
药
to
物
the provisional
换药
hospital,
了，
they
有
have
些加重，有些复发。
continue the
那么还有
treatment.
少
If
数
they are stock out, if they have
就是
stock
那
out
个
of their
本身
medication,
的
they
话
can
是
have relapse
跟
of
应
their
激有关的，
symptoms.
也就是跟我
And
们
also,
讲
the other
一个是
category
压
is
力状态，一个
distress
是本身这个
related
病，大家知
related
道还是有些
psychotic
捆绑，那么
disorders
跟应激有
because
关的
they
一些
are
一些
confined
精
in
神病
this
障碍
provisional
存在的。
hospital.
那么
So
大概
this
我们
is
在患
for
者群体里
psychotic
面，
disorders.
主要是这些
For
方面的
these
问题。
patients,
那么
these
对我
are
们
the
医生来
main
讲，确实是
mental
一
health
个，也是
problems.
一个，我觉得尤其精
So
神心理医生，
for
我们觉得也是个
our
挑战。因为第一个
psychotherapists
大
and
家知道，
psychologists,
我
we
们
also
精神
have
心
some
理科
challenges
它
for ourselves.
对这种
As we
感
understand
染
that
防护这一块
the
相对是偏
infection
弱的，所以我
protection
们做决定， 尤
training
其
for
像我
the
作为队长，
psychologist is
我们带领了
relatively
这4个
very
单位的
weak.
50位医生，有
So
分
the
在
50 health
9到
workers,
10
the
个
50
地方，所以还
psychologists,
是
they had
非常担心的。所
scattered
以我们
in
当时想，
10 different
这
wards.
个防
So
护
we
应
are
该是放
very
在第一位的，
worried
大
for
家应该
them
知
to
道，在早
protect
期我们
themselves very
把
well.
防护肯定是放在很
So
重要的
very
位置，尤
early
其我
on,
们做
we
这个
stressed the
精神心理
problem
服
of
务，大家知道，
protection.
如果你自己的
We
没有安
have
全感，
to
大家想想，
protect
我们自己
ourselves
没有安
first,
全感，
then
我们要
we
为
can
病提供
provide
这
the
个
psychological
支持，
service to other
就很
people.
困难，对不对？
This is
所以我
the
们最开
basis
始做
for
了很多
our
工作，还是
support.
用在这个
So
防
we
护。
have
当
done
然
a
我们也
lot
没很多
to
深度讲
train
座，
our
我们
staffs
从
to
早到晚花
protect
了1天时间。
themselves We took a whole day to train them and how to wear and take off the gown and the masks. The taking off part is extremely difficult for them. So this is to maintain our safety and so that they have a sense of safety. And then after this step, we need to understand the patient's need. And at early phase, a lot of patients and includes also healthcare workers, they think the problems are not mental problems. They would put that onto the pneumonia. Maybe they have some needs and which is not understood as psychological problems. For example, their needs could be manifested as their thirst for the information. What's the mortality rate and are infectious? They're asking questions like this. And why am I positive and negative and positive again? And also they have difficulties in their home. Maybe they have different family members in different hospitals and health facilities. They need communication. So these are the very actual needs from the patients, and we need to get to know them. In the past, when we were in the hospital, people come to us, but in the provisionary hospital, we go to the patients to understand their needs. So the COVID-19 is nothing like a normal environment. The psychologists, psychiatrists, they're in the gown, and this is a very large provisional hospital, and we have very few people in this large hospital. So under these circumstances, we need to contemplate at how to do it. And we are wearing the gown. How do we do the consult? So we are trying to find the right way and using the limited resource to provide service as much as possible. So for patients, we understand that there are a lot of needs for the patient. First of all, no matter it's made the patient or the healthcare workers, they're all reluctant to be labeled with psychological problems. They have some anxieties or sleep disorder, disturbance. They refuse to think this is psychological problems. They think this is just because of their disease. Once they're recovered, they would be rid of all these problems. So in the early phase, we support them to solve the patient's practical difficulties. We focus on that, and after solving these difficulties, we communicated with the patients on the pneumonia and also some prognosis, so some treatment. But actually, that's all psychological based. And we are the psychologists, and we may know very limited about the COVID-19 itself. So we need to provide, we need to learn, and so as to provide timely scientific information. And we work with infectious disease department and cardiovascular disease department. We need to do this MDT thing so as to provide the support as much as possible. We need to provide the information from every disciplinary, and we need to evaluate the patients together with the other physicians. So support patient. And for the psychological support, we want to do it face to face. We are wearing gowns, and there are some obstacles, as you would understand. The masks and the gowns would hide our expressions, of course. So we mainly use our language and words to do the therapy. And also in the hospital, we will spend some time in the hotel when we are not in the hospital. So at that time, we will use a social media platform to communicate with each other. And we want to do more things. But there are some ethical concerns. In the acute phase, we want to help the patients to decrease the risks. We give out the patient our WeChat number so they can talk to us on mobile phone. And so the patient can talk to us and they have more options. And we spend a lot of time to do a one-on-one consult with the patient. So we also posted our QR code of our WeChat so that the patient can add us and can talk to us on the phone. And also we have one people per day on duty. They're on call. If the patient have some emergencies, they can find support. So we were trying to provide different mental supports. It's not complex. I would like to introduce to you. Our objective is to increase the flexibility, mental flexibility, so that they can get through the most difficult part of COVID-19. And also later, we have some problems, but we didn't have enough human resource to solve every problems. We have several consult teams but it's
后面
not
我
enough
们
for all the
洪教授他们
hospitals
还有一
and
个团队
the
非常
health
的好奇，
facilities.
有
So
更多的
Dr.
服
Ma
务。
Hong led another
那么
team
其实很多就是我们讲，
there
对于我们患者来讲，他
to
需要有人
complement
在
us.
旁边，需要
So
有人
for a lot
听，
of
需要有
patients,
倾
they need
诉
people
等
to
等，这是
listen
我
to
觉得
them.
最
They
基
need
本
to
的，这是最
express.
早
This
期
is a
最基
very
本的。
basic
那
need
么
in
这样的
our
话，我们也
cases.
会为了我
So
们让他
for
有些事做，
these
也能
patients,
达到一些缓解
we
焦虑的一些
want
目
to
的，那么我
lower
们很
their
多请他用的一
anxiety
些放松
level,
的技术，
and we
因为我这
teach
样的
them
话
how
会
to
有更多的人
relax
去做，大家应该看到过，我们很多
so
在
that
方舱医院里
they
放
can
音乐
relax for
等等，
themselves.
其实都
We
是为
try
了
to
放
play
松在
music
做
in the
的。
professional
那么也教会他们一些正念的
professional
一些
hospital,
方法，音乐的
and
方
this
法。
is
那么
one of
少
the
数也会
techniques.
用的一些药物，
And
药物的
for
话，我们它
several
大部分是以
patients,
睡
we
眠的
teach
药物、
them
抗焦虑药物
mindfulness,
为主的，
and
少
also
数
for several
个别
patients, we
用了一些
use
抗抑郁
psychotic
药，那么
drugs,
还有个别我们用
some
的一些
antidepressant
抗精神病药
drugs,
用过的。
and
那
also
么极个别我
antipsychotic
们也会
drugs.
选诊的，就是我们在方舱医院我们发现，
We used to use
第
that.
一个是有些
And
病
if
复
we
发
see
了，
very
他也不后
severe
做，那
patients,
没
so we
办法，
also
他
do
有
the
一
referral
些
to
风险，
higher hospitals
有一些伤
or
害
some
这个
psychotic
民
disorder
众也或者我
relapse,
们患者的潜在
where
的风险。
if they have
那我们还在
some
选择我们
risk
专
for
科医
harm
院，我们
others,
定
we
点医
will
院，那
refer
同时
them
又可以
to
治
other
我们
designated
新冠肺炎，
hospital
同时还可
so
以治疗我
that
们精神
they
科问
could
题的
be
定点医院
screened
的治疗。
for psychotic
所以像我们
disorders,
武
and
汉精神
also
中
they
心当时
can
就是
be
这种医院，因为我们当时也是
treated
本
for their
院到
COVID-19.
武汉精神
So
中心做
there
治疗。
was
所以这个大
Wuhan
概是我们这
mental
个
health
工作
center
一个
for that
情况。
referral.
那么这里像我
So
们主
this
要
is
案例，因为
mainly
我们这
our
次这个
work.
活动
I
我
would
们
like to
跟这种
present with you a case
这种公共
because
精神卫生是相关联的。这
this
个案例
is
的话也
very
是
related to the public health
比较
emergencies.
有代表性的。
And
这
I think
个
this
案
is
例
a
的话，
very
她有将近70岁的女
classic
性，她也是因为
case.
新冠肺
This
炎
is a
还是有关系
69-year-old
住的方舱医
female.
院，但是她
She
本身
has
是个肺部情况，
COVID-19, but
是
also
不算严重，是
cardiovascular
作为
disease,
轻症
coronary
住进去的。
disease, but she
那么
has very
很遗憾
mild
的，她丈
disease,
夫在
so
她
she
医院
was
之前也
admitted
是
to the
因病去世了。
Provisionary Hospital. And
嗯，
before
那么她
her
小孩不在
admission,
身边，
her
2个小孩
husband
都在国
died,
外，
and
所以
all
没
her
办法在
children
在
were
接触她。那
abroad,
么实际上
were
她
not
成了
in China.
一个
So she
人
was
陪睡是这么
isolated.
情况。
She
那
was
么越以后
alone
的话，
in the
她情
provisionary
绪就一直不好
hospital.
情绪也
And
低
she
落，
has,
也发
after
烧
admission,
化，
she has been
睡眠
really
也不
low
好，
and
但
with
是她
very few
还算不
words
错。
and
为什么？她
sleep
症状不重，
disturbance.
能够
But
陪后
because
治
she
疗，
has mild
而
disease,
且
she
治了
can
一段时间以
cooperate
后，
with
她
the
肺部情
treatment.
况更
And
加好，
after
几乎
several
是
times, she has
没有什么
improved
看
lung
不到很多这
condition,
种我们的那
and
种
her
肾病
oxygen
病变，
saturation
然后
has
饱和
been
度基本上
improved.
正常的，心电图
And
也
she did
大
not
致是稳
have
定的，没
other
什么大问题。
uh,
那么很遗憾，
damages
她
in her
住
other
院2周以
organs,
后，我们
and
这个
her
她出院的
ECG
话
are
要
normal.
检测
But
2次
after
核酸
2
检测。
weeks,
那第
we
一次
have
检测
done
是
2 times of
是好的，是
nucleic
阴性
acid
的。
test.
那我们知
The
道一
first
般要
one
隔
is
64小时
negative,
还要做一次检
but
测，
we need
那么
to
第二
repeat
检测
that
又
test
得了阳性。
for
这个
another
在
time.
方
But the
舱医院里面
repeated
当时
test
在
came out as
患者病群里面还是有一定
positive.
的比例，大概不到
So
10%， 这个比例是存在的。
approximately
当然这里面很多原
10%
因，
of
有
the
比方说有可能这
these
个人群
people
的这
would
个
turn severe
有一定的这
disease.
个检测准确性，还有个采
She
样的
knew
这个情
that,
况，可能都
but
会
there are
有关
also
联。
some false negative and false
那么这个时候大家
positives.
知道，他又转
So
阳
we
性以
need to
后，这
do
个对他
2
打击是
times
很
of
大
the
的。
nucleic
本
acid.
身他
So her
就知识是
second
不够的
nucleic
啊
acid
这种。
test came out as
那么他这
positive.
个时候
She
他觉
thinks
得
she
自己
wouldn't
没有希
recover.
望了啊，他就
She
完全觉得自己
was
这个病好的
so
年龄又大，对不对？又是一个人，爸
despaired,
也不在了，
and
本身就我们知道
she
打
was
击是很
all
大的，这个
alone
时候就完
with
全
her
丧失信
husband
心，
gone because of
觉得自己没有
COVID-19,
希望，
and she just lost
所以这个时
confidence
候他
and all
开始
her
不释
hope.
放，
At that time,
拒绝治疗，
started at that
他就
time,
打
she
死要治疗。
refused to eat,
这个是
refused
我
to
们，而且跟我
be
们英语
treated, and
不愿
she
教的，
also pulled out her
晚上也睡不好，
intravenous
所以这
infusion
个情况就
tube,
比较难办了。
and
就是我
she
们
has
所有的医务人员都难办，为什
difficulty
么他不后
sleeping
做
at
我们就
night,
头痛了，
and
对
she
不对？
refused
不
to
后做，而且我
communicate
们
with all the
请了我
healthcare
们看了以
workers.
后，我们觉
So
得
at that time,
抑
she's
郁肯定是
becoming
明确
cooperative.
明确的抑
So
郁，
we
抑郁在
think
加
that
重，
she had
而且
depression, and
带到
she
这里，如
has
果
aggravated
因为治疗
depression.
确实没什么特殊治疗，但是它如果不
For
进
treatment
食，
per se,
这个
we
我们认为
have
这是一个
nothing
很大的
particular
风
for
险。
her,
大家
but
知道，这个年这
as
么
she is
大的年纪，这个
refused
心
to
脏还是有
eat
些
because
潜在的
she's
基础
nearly
基础
70
疾病。
years old
如
with
果不进食，那么带来的问题我们
comorbidities,
知道
if
还
she
是很
refused
高
to
的风
eat,
险。万一
there's a very high
电解
risk
质紊
for
乱，
her,
那你可能会带来
and
一些
she may has some
心
electrolyte
脏的这种问题，
disturbance,
所以
and
我们很
also
担心。
which will
这个时
lead
候
to
就很纠结怎么
maybe
办？
some
按照正
cardiovascular
常情况下，
events.
这个时候我们肯定
Under
会要
this
第一步肯定要
circumstance,
想到哪里去了，就要到专科医院
we
去，对
tried
不对？那我们当
the
时这个时
first
候大家
thing
知
in
道，
our
这
head
种情
is
况
to
下我们
move
很
her to
难的，
designated
首先的话
hospital.
转院的话就不
The
容易。第二个的话，
referral,
我们
the
也不太可
transportation
能
is
不希望
difficult,
像这样
and
的年纪这
we
么大的
want
老太
to
太，
avoid
她
that
又没
as
有
much
主
as
动性的
possible
风险，而且
because
是不
she's
吃
very
东西这个
passive
情况，
and she's
我们所以很
elderly.
纠结。按照我
She's
们
refusing
的
to
法律
eat.
规定是
So
可以这样
based
子
on the
转诊
law
的。当然
in China,
我
we
们
can
也需
refer
要
her to a
家属
designated
同意，但是她家
hospital,
属也不在
but we
身边，
need
所以我们
the
也可以通过这些
agreement
电
from
话、
the
视
family
频或者
member.
从
But
微
the
信来
family
联系。
members are not
那么
here,
家里人的话呢，
we
就是他
we
觉得
tried to
因为他不
contact
在
the
身
family
边，
members.
希望我们医
The
院做
family
决定。
members
这个情
hopefully
况是很
they
清楚
hope
的，就是医
our
院
healthcare
根据你
workers
的病
to
情，
make
根据他们需
decision
要
for
来
the
决定。
patient because they are
那么
not
这样的话，
there.
所以我们这个团队呢，
So
我们想了些
on
办法
behalf
呢，
of
觉得
our
还是
team,
第一步，还是
we sort
能
of
够做点
some
工作最好，所以
measures.
它
We
终
took
究
some
是有这
measures
个原因性带来的问题。 所
because
以
her
我们这
problem
里的
is
话，我
based
们
on the
想一想，这个
positivity
病
of her
既
nuclear
它既是
test.
新冠肺
So
炎，又是有抑郁，
this is a
这个
COVID-19 patient.
病情，
She
新冠肺
has
炎病
a
情是
very
没什么很大的问
alleviated
题的，但是
symptoms
只
and
是病
her
毒是阳性。
improving
这
lung
个时候，所以我们
decision,
讲，第一步我
lung
们还是请
conditions.
了一些
Yet
我们
she
一
has
起
a
查房，我们好让我
positivity
们感染科的
test
医生
on
一
her
起才能
viral
解释为什么
status.
会是阳性。前面讲的是理由，
We
这
first
阳
of all
性
we
对你多大的
discussed
问题，
why
以
she
他做了
still
一些解释。
tested
第二个的
positive.
话，我
We
们
discussed the
还是跟他
reasons
家
for the
家里人，我们
positivity.
2个小孩在
And
联系，就是我
secondly,
们能不能够，
we
还是定
contacted
期的
her
跟他
two
视频，尽管
children
他不愿意回答问题，
and
我们反
arranged
复让他听到他的声音，给他一些
regular
安慰。
video
那
calls
么我
with
们
her
没有办法，
children
因为他这个
so
情
that
况，我
she
们
can
还是
hear
派了一
and
个人
see her
进去，花
children.
时间陪他。
And
就是他尽管不
we
听，我们还是跟
designated
他讲
one
道理，
healthcare worker
讲他的这个
to
病
be
情的情
there
况，
to
为什
talk
么，
with
让
her,
他
to
为什
tell
么
her
会出这
about
个
her
情况，
disease
跟他的情
and
绪，
tell her why she's
抑
having
郁
this
跟他的
positivity
关联，
in this nucleic
大
acid
概
test.
我们讲，
But at the time, she
跟他
was
做了一些解释。
so
当然
mentally
他总
depressed.
而言之，我们从临床上来看，就他就是
And
完全不配合治
so
疗。从我
clinically,
们经济学
she's
来讲，
very
他完全有可能危
incooperative.
险他的自身的
And
这个
this
健
is
康的风险
very
存在的。如果
risky
我们不
for her
处
own
理，
health
会带
if
来这样的
we
问
do
题。
not if we didn't do
那么我
anything,
们的支持
there
里
will
前
be
面讲
very
了，我们就
severe
把所有我们
consequences.
的动员者，
So
我们
how
就
to
动员
manage
心理
that?
支持，我们就
We
动员了
mobilized
家属，
every
动
ways.
员
We
了我们
mobilized her
经济心理团
family
队，加上我们
members
院
and
感团
also
队，我
all
们给他
our
做了解
team and
释。
infectious team
然后
to
我们
talk
药
with
物
her,
方
to
面，我们当
explain
时
to
还
her
是因为年纪
her
比较大，我们也
COVID-19
因为他也本来
situation.
就不配合，
And
我
for the
们还是没有
medication,
考虑
because
药物，
she's
物
very
理几乎
incooperative,
做
we
不到。
didn't do
我们现在
medication.
最担心
We
的问
didn't
题就是风
administer
险管理，就
medications
是我
to
们怕
her.
万一
We
他
are
这样的话，
afraid that
前面讲了，
she
带
can
来他
have
的这个
some
躯体风
potential
险，有
risks.
些心脏的风险。
This is
这个时候
very
后来我们
uncertain.
跟他做了一些工作以后了，
So
他的这个
after
抵
some
抗 没
conversations
有那
with
么强
her,
烈的时候，我
her
们讲，我们也
resistance
跟他
is
说过，如果你再这样下
lowered.
去，我们医院也
And
没有
we
办法，我们
told
可
her
能会
um,
把您卷院。
we
卷
are
院的话，可
trying to
能有时
do
候可能带
good.
有一点外力的是带一些外力，
And we
这样的话
have
可能会更不好。
we are
这个时候
trying
他虽然还
we are
拒
not
绝，但
trying
是我
to
们讲
use
他已
some
经没那
external
么大
forces
拒绝了。
at
所以
that
这个时候我
time
们就开
because
始
her
还是跟他
resistance level
通
is
过
lowered.
给能量的办法跟
We
他说，因为
tried
他还是反
to
抗。这个时候我们
talk
就是还
more
是
with her
想到
and
还是
try to start
把他一些
infusion again, but
约
she
束，
refused.
轻微的把他手
And
来约
we
束一下，这样的话我们保证他的一
tied
个
her
病毒
hand
的一个
onto
基
the
本的生理
bed
需
to
要。
do some
那么经过这
mild
2次支持，应该经过我们这个他家里
tie
也反复
bandage
跟
of
他
her
来说，跟他
hand.
做视频，我们也拍一些进
And
去，
later we
他
arranged
还
some
是
video
有一些
calls
好转，就是我
for
们后来
her.
能够基本上
And
能够做一些
so
沟通，做一些沟通，
little by
就是能
little
够点头，能够
we
有表情。后来我们
saw
讲，
the expression
后来支持几
emerging
天
on
以
his
后，
face
我们
on
讲
her
你别急，
face,
我们再给你
and
做一
she's
次
talking
核酸
more.
检测，结果
And
做几
later
天以
we
后，做
repeated
检测我们知
again
道
the nucleic
他就是
acid
又
test for her,
变为阴性的。他
and
这样
she
的话，
turned
我们讲
negative
这个
again.
病我们讲，
And
尽管
later
我
she
们
was much
后来随
much
访，他
better.
没有彻底有这个情
And
绪
on
没
the
有彻底
follow-up,
缓解，但大致能
she
够
still
配
has
合治
some
疗。后来
mental
也
depressions,
阴性以后，我们也
but
把他卷
she's
到一
more
个隔离点，所以
cooperative
我们
than
这个时候也
before.
是特别提到，就是未来在
So
隔离点
in the
还有更多的风
future,
险，就是我们
there
要
are a lot
这
of
点我们特
risks
别要
that
关
we
注，就是
haven't
我们
seen,
要派专业的
and
人
we
来
need
关注他
to
这种情
mobilize
况，
our
这个情况。
professional
所以从这
healthcare
个案例里面，
workers
我们
for
除
them.
强调的
So
一
from
点，
this
就是我们一
case,
定要对这种
we learned from this
老年
case
人，年
that
纪比较大的，
for these
超他接
elderly
近70岁左右，
population like
而且
like
又
this
没有很多
lady,
社会支持的人，我们
she
觉得
did
这是
not
未来
have much
我
social
们要
support.
关注的一个
We
群
need
体。这
to
里面当然我们
focus on them. We
我们
need to
从我
give
们这个
them
整个
our
这个我们
attention.
国家发
They
布
are
能看
very
到，我们要关注
people.
患者、关注家属、
And
关注
we
一些
need
医务人
to
员。
look at
那么
these
实际上我们觉得，
patients, health
因为我
workers,
们
as well as the
这个
elderly
案例里面提示我们
population.
这个老年人，尤其那
So
种
elderly
孤
population,
寡老人，我们是重点的
especially
关注的。这个
isolated
在我们了
elderly
解情况下，
population, this
还
is
是
the
存在一些跟我们
focus.
自
They
杀有
have
关的一些情况会发生的，
a
尤其
lot
在
of
我们
potential
最
risks
担心
for
的还不是急性
disorders.
期，急性期我们见到的说实在的还是比
The
较少。
acute phase,
所
during
以
the
这种
acute phase,
易
we
感
have
群体我们是一定要
little
关注的。当然除了老年
elderly,
以外，儿童、
little
我们
people with
残疾人
little
士我们也
patients
要
who
注意。
with
当然我
psychotic
们最重要的是
disorder,
怕
but
这
in
种
elderly
这种
population, we do
硬
see a
体带来
lot.
什么？带来这些像抑郁啊、焦虑啊，我们
They
抗
are
伤后抑郁症
under a
啊，
lot of
这
stress, stress. They can lead to depression, anxiety, as well as
我们离开
PTSD.
以后，我们马洪老师去了
For example,
武
Dr.
汉，
Ma
我觉得
Hong,
他们可能最重要的
when
是这
she
一块。
was in
所以
Wuhan, she
所
saw
以
a lot
公
of
共卫生来讲，我
depression
们希望我们把
and
这个群体，我
anxiety
们
and
做一些预防，
PTSDs.
我们
So
能不
in
能
this
够
population,
降低
maybe
它的自杀的
if
风
is there
险？
any
这个是我们
possibilities, we can do
最
some
我觉得
prophylactic
要讲的
measures
最
as
重要
well
的一
as
点，就
to
是我们希
prevent
望了
everything
解
from
我
happening.
们这个群体里面
So
自
we
杀
need
风险究
to
竟有多
recognize
大
the
多高？
vulnerable
我们如
population
何
and
去
to
降低它
recognize
这种
their
风险，或者
risks,
甚至我们
and we need to take
减
measures to
用什么
lower
办法来
those
降
risks.
低？这是我们讲未来我们要做的。当然，我们说，我估
This
计我
is
们马
also
洪老
what
师
we
已经
need
做
to
了很多
do in
这
the
方面的工
future.
作，
And
也
I
是我们离开
understand
武
Dr.
汉以
Ma
后，我们
Hong
最
has done
担
a
心的
lot.
事
She
情。
will
我想
introduce that
这个
later.
未来国家也非
And
常重视，所
also,
以我觉得
we need
我们
to
应该会
look out
进
for
一步
suicidal
去
risks
做。
too.
好，我就有点
So
时间也
I
超了，
think
我就
my
先讲
time
到
is
这里，谢谢
limited.
各位。
That's all. Thank you, Professor Wang. You have mentioned in Wuhan, the psychologists are trying to approach the patients actively, and they have been trying to use different ways to communicate with the patient. And we can feel that this whole mental service has been very important in the outbreak. And as mentioned by Dr. Ma Hong, the psychology itself is not a biology problem. It's so much more. So in this team, Dr. Ma Hong, she has been a pillar in the mental health service. I also, Dr. Ma, she's a team member in the first people in the interventional team for public health and emergency. Let's hear from her.
Thank you. Is this okay? Thank you to all of the young people who have organized this session. And thank you to my old friend, Dr. Saxena from the WHO. My personal knowledge on psychological first aid I learned from WHO. I will talk about the case of Wuhan, psychosocial first aid in COVID-19 in Wuhan. My talk is divided into 3 segments. The first one is the difference of mental health provision in usual circumstances and in emergency circumstances. The second segment is source of distress and mental health needs. Dr. Wang already mentioned some practical needs. And the final is response and challenges in Wuhan. This is a calendar. I put little viruses on the calendar. This virus has been here for it is now May. It's been here for half a year. This reflects China's circumstance. The virus is growing smaller and smaller. But if we draw a map of the whole world, this calendar will look much worse. So we'll be living with this virus for a long time. What are the people have been talking a lot about mental health support recently. We've sent medical teams in, but we have to be clear on one issue. That is the mental health issues we talk about normally. Is it the same as mental health after large disasters? From these 8 aspects, they are different. After disasters, the source is the disaster. We were about to celebrate New Year's, but suddenly the virus comes. We can't continue our celebrations, and we can't even see the virus. Usually when we're at our office, we see various kinds of mental health needs. In terms of service provision, during disasters, we proactively provide services. Dr. Wang also mentioned we sent a national team in this time. Normally, we are passive service provisions. We are in the office and people come to us. A target population is different. Dr. Saxena mentioned that everyone who has needs should get services. This depends on how much resources we have, however. Usually, we provide emergency services in the acute phase. We have about 400 people coming here. Afterwards, after the acute phase, most of them left. I went later after most of them left. When disasters come, their services are basically free. It's covered by the national government, but normally we provide long-term mental health services, but this is all for a cost. The method of support is different. At this time, we provide psychosocial support. I will talk more about this later. But normally, we provide therapy or counseling with one or several techniques, or even medication. Post-disaster, who gives services? Are they only mental health specialists? No, everyone can provide services. But in normal times, it's mostly therapists who provide services. Their techniques are also different. Post-disaster, we provide mostly social support and companionship. But if there are severe cases, like the case that was just mentioned, then we need a specialty care. But usually most of the techniques used are therapy techniques. So these are two different issues. People usually think that any of us can provide mental health services at this time. But personally, I think people who have not had training, who do not understand disaster mental health, when they go out into the field, they won't be able to do such a good job, or they won't be able to help people as much. So mental health support or mental health services in disasters, what are our aims? This aim was put out by the United Nations. That is to protect and improve people's mental health and mental and societal peace in times of emergency. They have a series of workbooks. This series was published by the Interagency Standing Committee of the UN in order to better collect resources in different offices, including the WHO and other agencies that provide humanitarian care. They hope to use one set of guidelines for all of these agencies. The ones that I have listed here all have Chinese versions. You can see the last one, a briefing on mental health and psychosocial support in COVID-19. The first guideline was published in 2007. I went to WHO in 2008 during the Wuhan earthquake. That's when I studied the first guideline. It was the thickest and most difficult one. These are the covers of these guidelines. The one on the top left is the first guideline. The second one is the second one. The one on the right is the third one. And the fourth one, to building back better. This was very helpful for me. On the bottom right is the newest one. The United Nations ISC is an office in the UN. They specifically work on emergency mental health. This publication also has a Chinese version. So the first guideline is the most important. They mention mental health and psychosocial support. This is easy for me to remember because my name is Ma Hong, which is MH. So it's easy for me to remember. This is a long term, but we can't find a shorter way to translate it. What is emergency mental health and psychosocial support? It is any type of local or outside support that aims to protect or promote psychosocial well-being and or prevent or treat mental disorder. Anything, you can do anything. You can do it locally or from the outside. These two terms are closely related and overlap, but they reflect complementary approaches. These publications, you can download them. It's easily found through search engines. You can download the Chinese versions. There's another guideline that hasn't been translated on evaluation. So previously we've mentioned how disaster mental health is different from mental health in normal circumstances. Now let us look at the difference between the stress source. This also comes from a recommendation from the WHO. On the left is stress and anxiety about infectious diseases in general. For example, fear of infection and death, fear of loss of income. The third one, you might live in a place with a lot of infected people. There might be stigma or social isolation. Next is we may feel helpless to protect our family, or if I grow ill, there's no one to take care of my family. This causes a lot of worry. We saw this a lot in the communities this time. And people who are quarantined may feel frustrated, helpless, lonely, and depressed, especially people who were quarantined multiple times. Perhaps they were quarantined, they went to the hospital, they were quarantined again, they went home, but they might be tested positive again. So they have to be quarantined again. So they were continuously rotating within the system in these few months. So there are a few people like this. They have a lot of stress. So people in the field have felt that it's difficult to provide services for these people who retest positive. As for specifically for COVID-19, the stresses, first of all, is people are unsure of the mode of transmission. So people are very fearful of infecting others. When we go into the communities, people who don't have anyone infected in their families, the first time we go into their homes, they will say, for people who are discharged and are tested negative, their families reject them, ask them to go far away. Sometimes I say, this person wants to drink water. We look at them unsure. They're unsure if they can take off their mask and drink water. They're afraid of infecting others. Some people, if they have a fever, they might be stressed about whether I have this disease. Also, there are vulnerable populations who lack carers. For example, when the community has been blocked, many families with few resources have a lot of difficulties. From the Chinese New Year, I have been providing services online. I was incredibly stressed. I went to Wuhan on March 23rd. Before this, I was providing services online. So this is something after we have been talking about with people from Wuhan and on hotlines. We found that in the acute phase, the biggest issue was medical issues, testing and hospital beds, and difficulties caused by the lockdown, especially for people who are prepared to go home for the holidays. They don't have any food and supermarkets have closed. Suddenly they're locked down and confined in the city. In the recovery phase, rehabilitation and resuming life is becoming an issue. People are worried that they retest positive, worry about asymptomatic patients and long-term complications. I left Wuhan last week. There aren't a lot of people on the streets because everyone is scared. They don't want to come out. In the later phases, hotlines get calls about family conflicts. Previously, when we have conflicts, we go to work to avoid conflicts for a long time. But now we have to face these conflicts every day because we're all at home. We have no way to avoid them. And also we have issues surrounding stigma and financial distress. So we are now quarantined here. Our waste is medical waste, but we all tested negative. Why is our waste still medical waste? Dr. Saxena mentioned the UN's pyramid. In fact, the UN pyramid and the WHO pyramid are basically the same. On the top is specialist services. Second level is non-specialist service, face-to-face. But this time we have a lot of online services. The next level is increasing community and family support. The bottom level is personal help, self-help. In these 4 levels, on the rectangles on the left talk about who provides these services. On top is professional specialist. On the bottom is yourself. Now let's see how Wuhan did. Let's go from top to bottom. In terms of professional services, we sent 430 psychiatrists, nurses, and therapists. There are 3 types. One group went with the large medical teams, where they have perhaps one mental health worker for 130, 150 medical team. And we had a large medical psychiatric team of about 300 people. Now, I was the last person, so I am the 430th person. These people are set up in the hospitals, shelter hospitals, quarantine sites. They were in charge of ensuring the healthcare workers' mental health. The second job was to ensure patients' mental health. By the way, they have all left Wuhan. So I went in late March. Previously, it was a central government team leading this effort. Afterwards, this was handed over to Wuhan City. We quickly set up within the city a mental health team, special team within the government. We have a mental health person in every hospital and in every community service center. So we have 220 people in communities, in community health centers. Some of them are family doctors, some of them are internal medicine doctors, some of them are therapists or psychiatrists. In the second level, that is non-professional help, we see media support, psychological hotlines, and online platforms. We see doctors and social workers and therapists working together. This was very common in Wuhan in the early phases. Everyone was working extremely hard, but it wasn't very coordinated in the early phases. The next level is to increase social and family support. The number of people working in frontline communities have increased 10 times in these times after the lockdown. Usually they have about 7 people working in the community. Now they have 70. They have people from higher levels of government coming down to the communities to work. We have students, university students coming out for volunteer service. And we know various other departments have been providing masks and groceries for vulnerable populations. The last segment is in basic service provision. We need to think about how we can do in daily life. I'm not sure what I put here is right or wrong. The health code I didn't attend. The health code is something that you show when you go into supermarkets or into large places. They show your health status, so we can see you. So we are very worried if our code becomes yellow. If it becomes yellow, it means you've had close contact with someone. The next two issues, I think, I have it is social support, but also a psychological support that I attended. The second one was public mourning. A lot of experts recommended doing this. It is not just a ceremony. It is a very strong mental health support. Everyone in the country has seen what you've sacrificed in Wuhan. We mourn your family together with you because they didn't have a chance to say goodbye to their families. They were cremated right away. It was a difficult process. So the entire nation quietly mourning for 3 minutes. It was a strong mental health support for Wuhan. So I put a question mark on farewell party. This was a CDC case. CDC personnel worked very hard in this epidemic. They were working on finding cases, on finding, on testing, on prevention. If we didn't do a good job in prevention, we would have needed so many more doctors and nurses. Prevention really decreased the number of cases, but you might have discovered that none of our farewell ceremonies were for CDC personnel. Some people think that this is your job as a CDC worker. And they think doctors are heroes, but they don't think CDC people are heroes. But it's not true. Doctors are not the only people who are on the front lines. The public health workers from the CDC are incredibly important. If we don't celebrate their what they have done, then we have lost a huge part of our army. Unfortunately, they only gave a farewell for one team for 70 people. They had a small celebration. They were very moved. They said, "We are taking this in honor of all the thousands of public health workers we were in Wuhan for 90 or 100 days, it was worth it. So I think this is something that we have been trying to push, a high level mental health support activity that we've been pushing. This is an expert suggestion that I personally wrote. If you look at it, you won't think of it as psychosocial support. For example, I wrote that doctors should be living in hotels, that people should be providing resources, there should be people, we should provide clear and precise data. Is this mental health support? Of course it is. I was very anxious to have these done. Next, I want to talk about challenges. We had a lot of hotlines. Are you able to answer all of the questions? First, they were asking for beds. They were asking for people to look at their medical issues. So if you can't answer these questions, in Wuhan, they quickly listed the frequently asked questions. They had the answers to every hotline call taker. So I think we shouldn't open too many hotlines during these epidemics. The next one is online. So in the online platforms I've been working with, I was afraid to say I was a doctor, even though I am a doctor, but I really don't know how to answer their questions. And when they give me a CT scan or they ask about medications, I don't know which answer is correct, even though I studied the guidelines on treatments. I don't know how to answer. So, but I found that all of them were worried about the health needs. So I didn't know what I can do. In the end, I ended up helping them find resources. So anything that you do to decrease distress is correct. For example, I found a lot of doctors to join in our services. The social work system gave all of us a certificate. We helped them to find doctors in the early phases when there was a great need for doctors. But it was uncomfortable for me because I wasn't able to provide answers like the doctors did. I could only provide a little support. I didn't feel very useful, but I did help provide resources, which was of some use. Lastly is about recovery. This was what Dr. Wang mentioned that he was worried about. I'm also worried. We provided a lot of services initially, but what about afterwards? There are two ways. So in one scenario, the online services will continue to be provided. Another group of the patients will have to be transferred to local mental health services. We have 270 mental health workers on the front lines now. We did 3 sessions of workshops for them. And we did a needs assessment of each of the districts in Wuhan. This work will continue in the future. But there are still a lot of challenges. These are the Wuhan Mental Health Work Task Force. They hope to be able to find everyone who is in need and provide targeted services. Our leaders agree with this, but it is difficult to do. On the left is myself. I was the last one who came to Wuhan. I was the last one to come. I think challenges also include regarding systems, because systems don't come, the disasters don't come that much. If we set up a system and we don't use it, it will fall into disrepair. I really wish that we can use systems to provide services, but it's very difficult. We have the backbones of the system now, but we need to strengthen it. Another issue I want to emphasize is emergency mental health service is social service, and social support is part of mental health support, but it's not all of it. We, in the end, for PTSD, for depression, and for other pre-existing mental health conditions, we still need specialist services. This epidemic has been going on for a long time. Everyone is tired and burned out. This still needs our concern. Finally, I have two suggestions. The first is, as a psychiatrist, you may be required to provide services. You need basic knowledge on psychological first aid. For therapists, you need to be able to change the setting of your services, because these are usually single setting consultations. You need to work more on social support instead of psychological therapy. For a lot of people, in a lot of therapists, they stopped using settings. They stopped having rules in their services. So this is what I want to share with you. I don't know if I have gone over time. Thank you very much.
Thank you for your sharing. In the next session, we'll have the QA, and a lot of audience are all looking forward to it. Our first question is for Dr. Saxena. The question is that you have mentioned in your lecture that the social distancing is an inappropriate term. We need physical distancing. So while we are doing this physical distancing, how do we maintain our social life and to decrease the impact of this emergency on our social life? As we know, during this outbreak, a lot of people, they refuse to go out the door and to meet their friends. So how do we maintain our socialing? Hopefully you can tell us something about this question, and maybe you can recommend some of the ways that we can do.
Thank you very much for the question. We need to follow the precautions on physical distancing because we don't want to put ourselves at the risk of getting infection or transmitting infection. But during times like this, when the stress level is very high, we actually need all informal and formal social connectedness to be able to speak to our family, to be able to speak to our colleagues, to our friends. And that, fortunately, is very much possible using the telephone, the internet connections, the chats, and even the Zoom by which we are connecting now. So we have the infrastructure of the technological advancements which help us to be connected socially. It's basically about giving a ring to somebody and asking how they are and describing how you are, and sharing common concerns, sharing common information, and providing the kind of social assistance that is needed. So yes, face-to-face direct contact is important, but a lot can be done by a remote contact, which must be maintained, especially during a crisis like this.
好，谢谢。那您刚才
Thank
提
you.
到，我们现在
And you mentioned that
我们现在呢是在利用这个
now
新的
we're
科技技
using
术，
the
然后
new technology to help us to maintain our communication, also provide mental service. We want to know that Normally, the psychologist can do a face-to-face communication with patient, but now the technology, the remote communication with patient, how do we evaluate their risk psychologically?
Again, a good question, and there are many methods available to assess people's stress level as well as people's level of anxiety and depression. There are two major ways. One is questionnaires, which could be administered by internet or by phone. And these are questionnaires which have 4, 9, or even more questions, which can be filled up in a minute or up to 5 minutes. And these give a good idea about what the person's level of stress and anxiety and depression is. And these can be administered at a large level. It can be administered to hundreds and thousands and even more people without spending too much time and effort. And these questionnaires indicate the number of people who might have excessive level of stress and anxiety and depression, and those people could be benefiting by some amount of assistance, which could be again remote, a psychologist or a trained person contacting them by a chat or by a telephone or by a video call can actually help a lot in administering, in delivering the kind of care that is necessary. And during times like COVID, these methods are being increasingly used in China as well as elsewhere in the world. There is insufficient data about the effectiveness of some of these techniques, but when face-to-face direct interaction is not possible, one has to try these out. And there are also many internet-based apps which can also deliver care. But we need to be careful that we use those techniques which have at least some amount of evidence for their effectiveness. I must say that a very large number of apps available on the devices have actually no evidence for their effectiveness. So one has to choose and select very carefully. And national authorities as well as international organizations are providing some kind of guidance as to which interventions are useful and which others may not have any evidence for that. So both for assessment as well as for care, a lot of digital mechanisms are available. They cannot look after all the needs of all the people, but they are extremely helpful to take care of a large proportion of people. As I have shown in the pyramid that I showed, and also my colleague Ma Hong has very clearly mentioned how it was used in Wuhan and how that could be used in future. In fact, I would say that crises like this actually open up the possibilities for many innovations. And use of technology is one of those innovations which need to be used more and more, not only during crises like this, but also during normal times, because they are more efficient and they save time and money and energy. Over.
Thank you. You have mentioned that these new technology during their application and the new technologies application. You mentioned that we can use some questionnaires and telephone chats to understand the patient's condition. Now the WHO is the WHO issuing guidelines or recommendations for us to standardize our mental support for general population.
Yes, WHO is issuing guidelines about what can be done on mental health and psychosocial assistance during crises. And Ma Hong actually mentioned the WHO guidelines as well as the United Nations Interagency Task Force on Mental Health and Psychosocial Support, which are very explicit about what needs to be done. WHO still doesn't have guidelines about the digital delivery of these mechanisms, and it is developing that right now. And also WHO is increasingly becoming very involved in providing digital health technology for physical as well as for mental disorders. So we can expect in the next few months and years much more guidance on that. However, some universities and some other agencies already have some guidelines about which interventions are useful and which methods of delivering them have more evidence than others. So there is an increasing amount of data on that, including guidance from WHO.
Okay. Last question for you. No matter is Dr. Wang or Dr. Ma, they have shared some cases. Dr. Wang mentioned a 69-year-old patient. So for the elderly population under this emergency, what do you recommend for their psychological support? So the elderly population, because we're entering elderly society, they have a lot of psychological burdens. We have to focus on them, and their ability to express their need is weak. So what's your recommendation?
Yes, the elderly have much larger needs for mental health and psychosocial support during normal times as well as during emergencies like this. And they need much more active and in some way a different approach compared to others. One issue that is quite important is to take care of isolation and loneliness. So it is sometimes required for them to be isolated to decrease the risk of infection to them, whether in the family, whether staying alone, or whether staying in an institution like an old age home. That cannot be avoided. But as I was saying earlier, a much higher level of social contact is necessary. So people contacting them from a safe distance or by a telephone or a digital mechanism much more frequently than other people will need is quite important. And in addition, if the old person has a cognitive deficit or dementia, then it is very important to maintain a consistent approach and to convey information as well as support in a language that the person can readily understand. So simple language or simple visual material are going to be very necessary. We also know that many old people have sensory deficits. For example, they might have limited visual acuity, they might be hard of hearing, and so we have to use methods that can actually reach them by whatever methods are available. Lastly, old people are much more prone for depression and also for dementia. So proper assessment has to be done, especially during these times, to assess their level of depression, which might have increased, and also level of cognitive deficit, which might be increasing because of the stress, but also because of the nutritional problems and lack of sensory stimulation, which is very common during these times. So in short, older population will need more help and a very specific kind of help, which should be built into the guidance as well as into the support systems that are being developed. Over.
Thank you. And we look forward in the future, maybe WHO and other facilities will release more guidelines for us to support different kinds of populations and to support different countries to provide mental support. And also in China, we have a large population. During this COVID-19 outbreak, we have dispatched a very strong team, including Dr. Ma and Dr. Wang. And hopefully in the future, under the guidance of WHO, we can include more Chinese experts into it. Thank you.
Thank you.
Okay, so next we will move to Dr. Ma. We understand that since 1983 you have been a psychologist. It has been a lot of years. In the past decades, for patients with psychology disorder, and psychotic disorder, you must understand a lot that they are facing a lot of discriminations from society and the family member, and people are ashamed. They have this feeling of shame, especially in this COVID-19 outbreak. People maybe they are using discriminations against people from Hubei province or healthcare workers that are discriminated against. So after this disaster, how do we protect better the safety for them, to remove the shame and to remove the discrimination? And how do we prepare for the future? How do we do the intervention to guide the population? Thank you. Well, thank you. This question is especially uh, prominent in Hubei province. Actually, this is a lot of psychological teams are trying to tackle this problem. For example, in the Leishanshan Hospital, the Shanghai team, Dr. Cheng in the Shanghai team, he provided trainings for the healthcare workers and the patients, some psychocognitive training, to tell them you have to aware of the things the public they are afraid of the virus but not you yourself. So as a people from Hubei province, you need to understand that they are afraid of the virus itself. Actually, what we are afraid is the virus. We feel that a lot of people in Hubei province they are sick, and mostly in Wuhan. Wuhan is the most endemic area, so that I exaggerated my panic. So I decided to move away from the people from Wuhan. So cognitively, we equal the people from Hubei to the virus itself. But so while we are in Wuhan city, um, they do not call it the COVID-19. They call it that disease, or I got it, the it. I'm not that. So when you're referring, we call it the new coronavirus lung. They do not use the phrase of pneumonia. They refuse to talk about the disease. And when I ask them why, they tell us that this is the plague. We do not want to use the word. So maybe they have a limited recognition, limited idea of this disease. They would think of the disease very negatively, and they labeled with the disease a lot of negative things. So they refuse to even to say the word. And I used to find bad for a healthcare worker, infected healthcare worker. And after he's discharged and returned to work, he did not want to talk with his colleagues that he was admitted for the COVID-19. When I visited him as a psychologist, when, as you have said, when I started my career, please do not greet them when you meet them in the street. You do not greet them on the street and ask them, "Are you better? Are you feeling better?" So that I got used to it. But actually, every disease are the same. We do not want the disease itself, and they need some social support. So at this time, why I feel better is that they're less discriminated. I feel, but also the psychiatric hospital they are not provided with a lot of protective equipment. But that's the same case in the United States. But the psychiatry patients with COVID-19, they have the chances to be treated with COVID-19 and the psychiatry patients. And myself, I have seen 3 cases in the Wuhan's hospital. They are treated with COVID-19, and also they are psychiatry patients. And nevertheless, they are treated as other patients. So I'm very pleased that they are treated. And I suggest all of you to treat everything scientifically, and also to protect yourself very well, and to wash your hands and wear masks. And if you can care for Wuhan people, that will be better. Thank you. So for this emergency for the mental support, is there a golden window? What's the window period? And how can we do better for the mental supportive system? Well, during the Wenchuan earthquake in China, at that time, the psychological team was not even mentioned in the news. People do not attach great importance to that. But I worked with NHC for a lot of time, and I said to them, you need to dispatch something to dispatch some personnel to Dell. So I talked to the administrative. We have a golden time of 72 hours. They said, really? And I said, really? We also have a golden hours. So at uh, the field, people would be like, they're shocked. They feel numb. They can't judge anymore under the face of emergency and disaster. So I think psychological support should be provided as early as possible. And also, we are the same important during the convalescent phase. Well, in my perspective, I can't say an exact golden hour or golden phase because I arrived in Wuhan very late in March because I'm the backup and there are a lot of things to be done when I arrived. We have less than 2 weeks of overlap to go over their work, and Dr. Shi hand over his work to me. He's also dispatched from the NHC. But when I'm alone, I was working with the Wuhan experts, and I feel very stressed because I think this is the convalescence phase. There are a lot of things that we can do, and I feel short of human power, human resource. You can't just ignore this convalescence phase. They need more people. So for the emergency phase, I think we should provide the psychological support as soon as possible. And also later, we should also provide help in the convalescent phase. Yes, you need to protect yourself and provide the service as soon as possible. Right, that's the concept. We should be accompanying the patient and during the panic. Well, I have another question. We are discussing a lot about the healthcare workers in Wuhan and in Hubei province. But for in other provinces, maybe the health workers they're not at front line, but they are traumatized by the COVID-19. How do we support them mentally? Do we have mechanisms for that? And for ordinary healthcare workers in the future, how can they do psychological evaluation themselves, and how can they call for help? Well, um, every people have their own resilience level, flexibility level, and the people they all grow through disaster. First of all, you need to trust yourself. You need to trust your resilience. It's not you're beaten up by the disaster. This is the first point. And the second is that we have mentioned the pyramid. The bottom of the pyramid is self-protection. We need to construct our mental protection level and to be more resistant against the disasters and diseases so that you can um, get together with the healthcare workers to support yourself. So my recommendation is that first of all, in normal time, you want to have more social contact. You during normal time, you can't just stay at home and be lonely. So you need some social support at normal time, and you need to have some hobby. If you stay at home, you need to have some good friends and hobbies and exercise hobbies, and you can't be too picky about food. So I think this is a very important psychological support. This is for everyone, every healthcare workers and general population. Thank you. And the next question is for Dr. Wang. Dr. Wang is from the Shanya Second Hospital, and he's also a part of Dr. Yang Jiasen's team. I want to ask you that you mentioned in Wuhan, the psychological support is a multidisciplinary work. You were working with the local infectious disease healthcare workers, and you participated in the world round to provide psychological support. So, in the future, what's the collaboration between the psychology department and other departments, especially in this outbreak emergencies? How do we construct this system to collaborate and to provide this support? Well, I think this is a very good question because the COVID-19 outbreak, this is a very special outbreak because we haven't been through this such disaster. This is unprecedented, and we understand that during the acute phase, Dr. Ma has mentioned, everybody is part of it because, uh, for example, the healthcare worker in the hospital, they are short of hand, and we are short of personal protective equipment. Even even wearing a gown and taking off the gown will take us hours, and we have calculated that every ward round we have very short contact time with every patient. We have to do a lot of things during the short time, so we have to be very technical. We have used some techniques. First of all, uh, we need to interact with the patient so that they can benefit from this time. Maybe some words and some expressions and some gestures would help the patients a lot. And we also train the healthcare workers in several hospitals so they can communicate with the patients in that way. And maybe they can spend 1 minute or 2 minutes with the patient. If they are trained with these little techniques, they can interact better with the patient. And the second is that a lot of people in China, they cannot express uh, um, their concern as psychological problems. They think they're all virus caused. They do not label it as psychological problem. So first of all, we have to relieve their concerns about virus infection, about life, about cardiovascular system. They have several concerns. Their concerns are all based on the disease, but they're questioning your identity as a as a psychologist. So this is where you want to work with the infectious disease patient, disease doctors. We want to collaborate every physicians together. We want to teach them, and when they are talking with the patient will give more credibility to them instead of giving credibility to psychologists. So this is what we did. I think this is a very good influence. And when we talk to the health worker, we are equally talking to the patients. So I think this is a very good work that our team has done. We have done a lot of work because we're all sweaty and it's very exhausting. So and also we have somatic symptoms and psychological symptoms. They maybe have some somatic manifestations, and they have needs all over, all around needs. So this is very true during the COVID-19, and this is why we really focus on the MDT. But the collaboration still need a lot of collaborations and time. We need to trust each other and we need to do a lot of trainings, and also our psychologists need the training from other disciplines so that we can improve our work. So we need to focus on the healthcare workers. It's still sufficient. They're under a lot of stress, and they are supposed to have to be okay all the time. So we want them to know that they have the chance to recognize it and ask for help. You just you cannot you don't want to hide the burden all to yourself as a healthcare worker. They need to recognize their problems and to call for aid like timely. We need to tell them that. Okay, thank you. My last question is also for you. Since April, a lot of healthcare workers they returned to their original hospital, and after spring isolation time, after May 1st, the vacation, they will return to their post. But they have been in Wuhan for a lot of time, for a long time. Now they are returning to their own work. What's your recommendation for them to returning to their normal work? Well, this is also a very good question. This is also what we worry about. Actually, because there are more than 40,000 healthcare workers going to Wuhan, they have their own resilience level. Most of them are fine, I think. But what worries me most is that healthcare workers, they are all people. They are part of the patient themselves because they're in contact with a lot of patients. They have a lot of stress levels, and also they choose physician as their career. They maybe have a higher anxiety level. They might be perfectionists among healthcare workers. So they are at higher risks for psychological problems. So these are also a vulnerable population if they're perfectionists or have higher anxiety level. So our administration bureau, they should provide some spaces for them and also to give them chances to take care of themselves. And also, some people ask me, I think my skin is darkened and my hair is feeling fragile, but that's stressful. But they wouldn't feel it as stress. They would think this is my body going wrong. And also, they could have some attention span problems and memory disturbance. This is also caused by stress. After they returning to the normal work, they will be stressed again, especially the surgeons, for example. If they have not returned to the perfect psychological level, they could again stressed by their own ordinary work, and also this could result in some medical emergencies, medical mistakes. So they should be evaluated before they return to work, I think. But how to do that, like overally, or and also at the same time to protect the privacy, it will be difficult. And I think we should construct a platform, some platform that we all trust. They can go into the platform and evaluate, and the system would tell them what the result is and what you should do. I think that system is very necessary. And I think that should be a very good evaluation for routine examination, screening for the healthcare workers. And I think that would be good for them. They should protect themselves before they take care of the patient. So I really do worry about that. And I think through some stress management, we can lower the risks, but we also need to look at it. Yes, hopefully later we can have such platform. Our last question is for you all, for all of the speakers. The psychology field, as I understand, the university do not include it as a curriculum, but in the Xianyang University, they have a curriculum there for their undergraduate students, but uh, it guarantees that students can receive such educations so that they could maybe understand more about psychology. And as we know, we are lacking such healthcare workers in psychology. How do we include more medical students as well as clinicians to participate in the psychology department? How do we attract more high school students to be interested in psychology? I want to ask all of you, uh, how do you see the uh, training of talents? I'll start first. I still want to say comment because I'm still uh, so I returned with the last team. I was the last team to be back from the Wuhan. I was met with a lot of great specialists, and we have a lot of discussions when we were in the isolation. Actually, a lot of uh, the specialists they worked in ICU, and they told us how they care about the patient. For example, one of the professors he said he trained for all staffs for three things. One is treatment, one is infection control, the other is psychology. So taught every staffs after they have worn the gown. If you got into the patient's room, you can stay for 5 more minutes. That's the best support for the patients. That is the requirement. And also Dr. Li Taisheng from Peking Union Medical Hospital, and he conducted that when he entered the patient's room, he would be close to the patient's ear and shout that to introduce himself. Uh, you need to stay calm. You need to hang in there. You can be okay. So that's what they did. And I think in the ICU, because we cannot enter the ICU room and they are conscienceless, but it's still important for them to shout to the patient's ear about some encouraging word. And also, this is psychology support should be a part of every health worker's, care worker's career. And I think it's very important. Secondly, for the medical students, and also every clinicians. In Peking University, we used to have a psychiatry and psychological department, but later it's cancelled. I think this actually optional, I think. But if you think if you're from a medical student, you can choose this specialty. But if you just enter the psychological department, you can lack common knowledge about medical issues, uh, so that you can just take the general medical education, and later you can enter the specialty of psychology, so that you could be more overally prepared on the medical level. And also, worldwidely, they do not have a very specific psychological departments. And the best scenario would be after they have chosen to enter the clinical field, they can receive the medical education and then opt for psychology department. And I think this is a very good field. I welcome all of you to choose us. Thank you. And then Professor Wang, please. Well, yes. When on the professional development level. And I think it is very true. This is a very good field. And in China, because we have a large base of population, so we really lack the psychologists. And in the short term, we do need a lot of students and personnel in our psychological field. But what's the transitional phase? Maybe we need some 30 or 40 years. That's a lot of time. Maybe we need 50 years. So 30 years has passed and we still need a lot of people in this field. We are at less than 3 therapists, 3 psychologists in 100,000 populations. So that's a very low level compared to worldwide levels. And maybe we want to do the basic service first, and we have a large lack of personnel. And I think maybe it's because the pay. So maybe the government can issue some policies to support us, and this specialty itself, I think, is very attractive. Because we are facing with the most complex disease and complicated cases, and also your personal skills is very important in this field. And this is also very flexible, internet based, to be internet based. So this is a very good field. You could live very well, and I would do welcome all of you here. And and but we have very low pay, especially in the general hospital. But I do believe that in the future we will be supported by our government, and our pay will be balanced. In the 1980s, uh, in the 1980s, psychologists are like paid as the same as surgeons, but now it's not ever the same. So maybe we should be paid based on our ability and the time. That might be that might be true in the future. We should get paid based on our skills, and I think that's possible in the future. That might be the path we will take, so that I think this occupation might be more and more attractive in the future. And I do welcome all of you, and we do need a lot of trainings and volunteers to participate in that, and we do have a lot of needs, and we need more attention from the general public. And hopefully more of these courses can be conducted and more people can get 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 to know it. Thank you. And hopefully in the future our government could invest more in the psychology field, and more people can recognize the importance of psychology. And also hopefully in the future more students can choose all of your universities to participate in this very promising field, a very promising occupation. Well, there is a saying. We are seldom curing, but often comforting our patients. I think that's very true. And psychology is also a constant topic. Dr. Ma has mentioned that we can go out of disaster and back to our normal life. And I thank you for all of your sharing. Thank for our audience and all of work behind the stage. And also thank you, Dr. Xuling from the Beijing 6 Hospital, and also Dr. Wang from the UNA's Beijing office. And tomorrow we will be returning to our work, and hopefully you can embrace your work with a nice mood. Thank you. Bye. Bye.